In this presentation, we will explore physical and cognitive development in middle adulthood, the period spanning roughly ages 40 to 65. This is a developmental phase that has often been overlooked in counseling literature, yet it is one of the most generative, complex, and clinically rich seasons of life. We will revisit our case study, Elena Rivera Thompson, now projected into her mid-40s, and use her story to ground theory in the lived realities of midlife. This module has 5 interlocking objectives. First, describe the physical changes that mark middle adulthood, from sensory shifts to changes in reproductive and cardiovascular functioning. Second, analyze cognitive development, distinguishing fluid from crystallized intelligence and applying post-formal thought, wisdom, and cognitive reserve. Third, center culture and equity, examining how race, gender, class, and access to care shape midlife. Fourth, apply a neurodivergent lens, recognizing how ADHD and autism often present and are newly identified during the middle years. And fifth, translate this into clinical practice using Baltes's selective optimization with compensation model and post-formal thinking. Middle adulthood spans roughly ages 40 to 65, but those boundaries are flexible and culturally constructed. Western definitions emphasize career trajectories, while many non-Western cultures define midlife by generational role transitions. Becoming an elder, a grandparent, the head of a kinship system. About 1 in 3 U.S. adults is currently in midlife, and this group carries most of the country's caregiving and economic productivity. The midlife population in 2026 is also generationally diverse. Older millennials and younger Gen Xers are now in their 40s. Core Gen X has become the sandwich caregivers, and younger boomers stand at the threshold of late adulthood, redefining retirement. Elena works as a registered nurse and bilingual patient navigator at a community health clinic. At age 38, she received her own ADHD diagnosis after recognizing her patterns in her son's evaluation. She has been married for 16 years and is raising 2 children, ages 11 and 14. Her mother, Maya, 74, was recently diagnosed with mild cognitive impairment, and her father, Daniel, 77, is Maya's primary caregiver. Elena is in the sandwich generation. Physically, she is perimenopausal, with increased fatigue, vision changes, and borderline hypertension. The sensory sensitivities present since infancy have intensified under stress. Internally, Elena reports a strong sense of generativity at work, paired with exhaustion at home. As she puts it, "I never thought I would feel this stretched. And yet, I have never felt more like myself." That paradox, the simultaneous sense of strain and clarity, is the felt texture of midlife for many of our clients. We begin with physical development. The phrase physical decline dominates much of the popular discourse on midlife, but that frame is incomplete and often inaccurate. Some systems do age, some compensate, and some functions actually improve. The clinical task is to help clients hold these changes with accuracy rather than catastrophe. Visible aging is biological, but the meaning of that aging is cultural. On the biological side, the decline of collagen and elastin produces wrinkles, and the decline of melanocytes produces graying. About half of men by 50 and 40% of women by 65 experience androgenic alopecia. Body composition shifts with sarcopenia and increased abdominal adiposity. Bone density declines as early as age 25, and women lose density rapidly after menopause. 1 in 2 women and 1 in 4 men over 50 will sustain an osteoporotic fracture. These are real, measurable changes. But what they mean is shaped by culture. In mainstream U.S. contexts, visible aging is something to fight, fueling a $60 billion anti-aging industry. In many indigenous, Latin, East Asian, and African communities, graying hair and visible aging mark elder status, wisdom, and spiritual authority. Women face stronger pressure to conceal aging than men. The clinical implication is direct. Ask what aging means in your client's family and community before assuming distress. Sensory changes follow predictable patterns. Around age 40, presbyopia, the progressive loss of near focus, sets in, which is why reading glasses become a midlife rite of passage. By age 60, roughly 92% of adults need vision correction. Hearing changes more quietly. Presbycusis is age-related high-frequency hearing loss, accelerated by occupational noise and personal listening devices, often unnoticed for years because adults compensate. 1 in 3 adults aged 45 to 64 has measurable hearing loss. Taste bud regeneration slows, and we lose roughly 30% of taste bud density by age 50. Hyposmia has gained attention recently because impaired smell is now an early biomarker for some neurodegenerative conditions. For counselors, sensory loss can drive social withdrawal, irritability, and depression. Women's reproductive health in midlife is a continuum, not an event. Perimenopause begins in the late 30s or mid-40s and can last for years. Hormonal fluctuations produce irregular cycles, sleep disruption, mood changes, hot flashes, and the cognitive shifts women describe as brain fog. Menopause is defined retrospectively as 12 consecutive months without menstruation, with the U.S. average age of 51, though Black and Latina women in the SWAN study reach menopause earlier and report more severe vasomotor symptoms for longer. Postmenopause follows, with estrogen and progesterone stabilizing at low levels. Black women are 2 to 3 times more likely to undergo hysterectomy before age 45, often without equivalent fibroid education or non-surgical alternatives. Cultural framing also shifts the experience itself. In Margaret Lock's classic work in Japan, women reported lower hot flash rates, partly because language, diet, and the cultural meaning of midlife shaped their perceptions. As counselors, we screen for medical mistrust, dismissed symptoms, and the emotional toll of being unheard. The body is biological, but the experience of the body is always relational and cultural. Men's reproductive health in midlife is real but less abrupt. Andropause is the gradual testosterone decline of roughly 1% per year after age 30, but reproductive capacity persists much later than in women. Erectile dysfunction affects roughly 40% of men at 40 and 70% at 70, with causes that include vascular disease, diabetes, medication effects, depression, and relational stress. Black men face roughly twice the prostate cancer mortality rate of white men, a disparity rooted in delayed screening, mistrust of the medical system, and unequal treatment access. On sexuality, Masters and Johnson's 1966 work overturned the assumption that older adults are asexual. Decades of research show that many midlife adults report stable or improved sexual satisfaction, tied to relational depth and reduced performance anxiety. And LGBTQ+ midlife adults face distinct stressors, including late life coming out, prior medical mistrust, and historical exclusion from sexual health research. Midlife is when the cumulative effect of decades begins to show in organ systems. 1 in 2 U.S. adults at midlife has at least one chronic condition. Heart disease is the leading cause of death for both men and women. And critically, roughly 65% of midlife chronic illness is preventable through lifestyle and screening. Cardiovascular and metabolic concerns dominate. Atherosclerosis develops over decades and presents in midlife. Hypertension is often silent, which is why it is called the silent killer. Metabolic syndrome, sometimes called Syndrome X, clusters high blood sugar, high blood pressure, low HDL, abdominal obesity, and family history. Type 2 diabetes prevalence accelerates after 45. Other systems also show wear. Vital lung capacity diminishes. Bladder function changes, and urinary incontinence affects many midlife women but is often unspoken. Cancer is the second leading cause of death. The takeaway for counselors is that midlife is when 30 years of behavioral choices produce a visible signal. That is sobering but also empowering, because behavior change in midlife produces measurable health gains. Most chronic disease in midlife traces back to a small set of modifiable risks. Tobacco remains the leading preventable cause of death in U.S. adults. Alcohol carries long-term risk for liver disease, multiple cancers, hypertension, and depression. Sedentary behavior is associated with cardiovascular, metabolic, and cognitive decline, and midlife exercise is one of the strongest predictors of healthy late life. Chronic stress and loneliness, in Holt-Lundstad's meta-analysis, carry mortality risk equivalent to smoking 15 cigarettes a day. Eating disorders are increasingly diagnosed in adults over 50, sometimes new and sometimes long unrecognized. On the positive side, Rowe and Kahn's 1997 model of successful aging names 3 components: avoiding disease and disability, sustained engagement, and cognitive and physical vitality. Stowe and Cooney note that framing disability as the absence of successful aging is ableist. Many adults age successfully with significant disability. Hold the model loosely, integrating it with disability justice and cultural humility. The hopeful message is that it is never too late. Now we look at health equity. The life expectancy gap between Black and white U.S. adults at age 40 is roughly 4.5 years, driven not by genetics, but by the cumulative biological cost of racism. Geronimus calls this weathering. Chronic activation of stress physiology produced by racism leads to accelerated biological aging visible in midlife. Indigenous adults face disproportionate burdens of diabetes, cardiovascular disease, and unmet behavioral health needs, compounded by historical and ongoing trauma. Rural midlife adults face rising mortality from what Case and Deaton named deaths of despair, driven by opioids, alcohol, and suicide. As counselors, we screen for medical mistrust and missed care without assuming noncompliance is purely the client's responsibility. We explicitly ask about access barriers, insurance gaps, transportation, time off work, and language access. We validate the weight of weathering. Symptoms in midlife are often not the first signal. They are the loudest ones. And we connect clients with culturally affirming, community-based resources, including Indigenous health services and community health workers. A piece of midlife clinical work rarely taught explicitly is neurodivergent midlife. Adult ADHD diagnoses have surged in adults over 40, particularly in women and people of color, who were systematically missed as children because diagnostic criteria focused on hyperactive boys. Many midlife adults learn they are autistic only after a child's evaluation prompts self-recognition. Decades of masking, the active suppression of neurodivergent traits, is now understood as a major contributor to midlife depression, anxiety, and burnout, especially for autistic women. There is also a hormonal layer. Perimenopausal estrogen fluctuations modulate dopamine and executive function, intensifying ADHD and autistic features in ways that clients experience as a sudden worsening. Listen to Elena at 38, the year she was diagnosed. For 38 years, I thought I was lazy, scattered, and broken. The diagnosis did not give me ADHD. It gave me a name for what I had been carrying my whole life. The grief surprised me. So did the relief. That mix of grief and relief is the typical landscape of late identification. Counselors should hold space for grief about lost time, reframe lifelong struggles through a neurodivergent affirming lens, and screen for masking-related burnout. Now we turn to cognitive development. The popular narrative is, your brain peaks at 25 and goes downhill. The research tells a far more interesting story. Midlife cognition is different, not lesser. And in many domains it is deeper, more integrated, and more flexible than at any earlier point in life. Let us walk through what is actually known. The scaffolding theory of aging and cognition, STEC, proposed by Reuter, Lorenz, and Park, remains one of the most generative frameworks in aging neuroscience. The core idea is that the aging brain undergoes structural changes, and it compensates by recruiting additional neural networks. Midlife adults often show bilateral activation, using both hemispheres for tasks that younger adults complete with one. This is not damage. It is scaffolding. The default mode network, most active when we reflect, Remember autobiographical material, or make meaning, becomes more active and more integrated in midlife. Cognitive reserve, built through education, novel learning, multilingualism, and social engagement, protects against decline. A useful metaphor for clients. If the young brain is a sprinter, the midlife brain is a long-distance runner who has learned the terrain. The runner is slower over 100 meters and far better at navigating a 26-mile course in changing weather. For practice, we reframe decline narratives as adaptive reorganization, promote cognitive reserve through novel learning and social engagement, and honor reflective pacing in session because the default mode network does its best work when it is not rushed. Let us get specific about what changes in midlife information processing and what does not. On the side of what slows, reaction time has been gradually slowing since the early 20s. Experience usually compensates. Working memory shows a modest decline, particularly under heavy multitasking demands. Episodic memory becomes more vulnerable under pressure. Midlife adults often describe tip-of-the-tongue moments and stress-sensitive recall. Divided attention becomes harder when both tasks are complex and unfamiliar. On the other side, much holds steady or improves. Selective attention is maintained for familiar tasks, which is why midlife professionals often outperform younger adults in their own domains. Semantic memory, including vocabulary, world knowledge, and conceptual networks, continues to grow into the 60s and beyond. And implicit memory, the procedural knowledge our hands and bodies hold, is remarkably durable. The clinical takeaway: help clients distinguish aging-related slowing from progressive cognitive decline. Most midlife memory complaints reflect normal change plus stress, sleep loss, and untreated mood symptoms. The qualitative shift in how midlife adults think is captured by two related bodies of literature: post-formal thought and wisdom research. Post-formal thinking extends Piaget's formal operations into adulthood. Sinot and others identify several features. Relativistic thinking is the recognition that knowledge is contextual and multiple truths can coexist. Dialectical thinking is holding contradictions without prematurely resolving them, the both-and rather than the either-or. Pragmatic thought is logic in service of context, where decisions weigh ethics, relationships, and consequences. And reflective judgment is the ability to hold uncertainty as wisdom rather than failure. The Berlin wisdom paradigm, developed by Baltes and elaborated by Gluck, identifies 5 components of expert knowledge about life: rich factual knowledge, rich procedural knowledge, lifespan contextualism, value relativism with tolerance, and recognition and management of uncertainty. Wisdom is not a personality trait. It is a developmental achievement most often built through experiences of struggle, loss, and meaning-making, all of which midlife provides in abundance. As Gluck puts it, wisdom is not the absence of doubt, it is the willingness to act with care while doubting. Midlife mental health is paradoxical. On one hand, the total incidence of most psychological disorders drops by age 45, including substance use disorders and schizophrenia. On the other hand, self-reported life satisfaction follows what economists call a U-curve, with the lowest levels in the late 40s and rising afterward. Depression remains the most common form of psychological distress, with elevated risk in perimenopause and during the sandwich caregiving years. Income, caregiving load, and racial stress predict midlife distress more strongly than age itself. When we hear someone reduce a midlife client's distress to midlife crisis, we should push back. The risks are structural and relational, not maturational. Clinical priorities: screen perimenopausal women for depression and anxiety, since symptoms are often dismissed as hormones. Assess caregiving burden in sandwich generation clients. Take suicidal ideation seriously, particularly in white, rural, and recently unemployed midlife men, where rates are rising sharply. Differentiate normal grief and existential reckoning from clinical depression. The existential midlife review is not pathological, it is developmental. Western developmental psychology has long defined midlife by individualistic markers: career peak, midlife crisis, empty nest. But cultural frameworks teach us that midlife also has communal and spiritual dimensions. In many indigenous traditions, midlife is a passage into elder responsibilities, caretaking, language, and intergenerational knowledge. Aging is not loss, it is service. In Latin cultures shaped by familismo, midlife is often defined by the central role in a multi-generational family system. Caregiving is honored, though it is increasingly strained as migration and economic pressures reshape family configurations. East Asian filial piety creates clear cultural expectations for midlife children to care for aging parents, with new tensions for second-generation immigrants, negotiating competing expectations across cultures. In African and African diasporic communities, other mothering, eldership, and spiritual leadership often emerge in midlife. Black women, however, also bear the strongest weathering burden from cumulative racism. We cannot apply a generic developmental script to a culturally specific human being. Always ask what midlife is for in this client's family, community, and tradition. Now we move from theory to clinical application. Paul Balti's selective optimization with compensation (SOC) model, abbreviated SOC, provides counselors with a flexible, strengths-based framework for midlife clients. There are 3 pillars. Selection is helping clients name what matters most now. Midlife requires letting go of some commitments to honor priorities. For Elena, this looks like stepping back from extra hospital shifts to be present for her teenage children. Optimization is identifying and amplifying existing strengths. What is already working? Build on it. For Elena, this means leveraging her bilingual fluency and lived experience as a patient navigator to transform a personal characteristic into professional capital. Compensation is developing new strategies to work around limitations. Compensation is not surrender, it is creativity. For Elena, this looks like ADHD-friendly scheduling tools, reading glasses for early presbyopia, and weekly family check-ins to manage the cognitive load of caring for both children and aging parents. SOC is clinically useful precisely because it does not pathologize change. It treats midlife development as an active design process rather than a passive decline. Let us bring all of these threads together with Elena at 45. Through the physical lens, Elena is perimenopausal, borderline hypertensive, experiencing vision changes, and noticing intensified sensory sensitivity. The equity factor. As a Latina woman, Elena's symptoms may be dismissed in medical settings, with direct counseling implications around medical mistrust and self-advocacy. Through the cognitive lens, Elena's crystallized intelligence is at its peak. Her clinical expertise, bilingual pattern recognition, and cultural fluency make her exceptionally effective. Her fluid intelligence slows under sleep deprivation, but her post-formal thinking is visible in how she navigates competing demands without collapsing into either-or framing. Through the neurodivergent lens, Elena's late-identified ADHD comes with grief for lost time and relief at recognition. Estrogen fluctuations are intensifying her executive function challenges, and her lived experience now informs her clinical empathy. Through the cultural lens, her bicultural identity is sustained but strained. Familismo expectations are powerful. The loss of her maternal grandmother continues to shape her caregiving stance, and sandwich generation pressure is immediate. No single lens captures Elena. Integrative case conceptualization in midlife always requires holding multiple frames simultaneously. 6 takeaways to carry forward. First, midlife is a generative, complex, and clinically rich period that has long been understudied. Your work with midlife clients fills a real gap in the field. Second, physical changes are real and reorganizing. Frame them with accuracy, not catastrophe, and always ask what aging means in the client's culture before assuming distress. Third, cognitive change is multidirectional. Fluid intelligence slows, crystallized intelligence grows, and post-formal thinking and wisdom are genuine developmental achievements of this period. Fourth, neurodivergent profiles are increasingly identified at midlife. Hold space for grief about lost time, the relief of self-recognition, and the identity reconstruction that follows. Fifth, health and developmental experience are unequal. Race, gender, class, place, and disability shape who ages well. Practice from a culturally responsive, equity-oriented stance, not as an add-on, but as a foundation. And sixth, use Balti's SOC, post-formal thinking, and integrative cultural frameworks. Your midlife clients deserve more than the midlife crisis script. They deserve a counselor who knows the developmental terrain. This module integrates current research from gerontology, neuroscience, counseling, and equity-focused public health. The references mix foundational works with contemporary updates that bring cultural humility, neurodiversity, and structural inequality into the developmental conversation. Take care of yourselves and bring this material into clinical practice with the care, curiosity, and cultural humility that midlife clients deserve.